Hello, I'm Doug McDonald. I'm one of the immunologists at Boston Children's Hospital. And I want to thank David and Tom and Stephanie for inviting me to participate in the Heterotaxy conference over the next couple of days. I'm going to present a discussion about immunologic management of patients with heterotaxy and asplenia, or polysplenia syndrome, and trying to keep these patients safe from overwhelming infections. So I will share my screen for my presentation today. So I just want to start off by stating that I have no conflicts of interest to disclose. So the goals of immunologists for patients who have heterotaxy and asplenia or polysplenia syndrome is to minimize their risk of infection. And obviously that can be influenced by the severity of their cardiac defects, the presence of asplenia or hyposplenia, as well as in a subset of patients, defective ciliary function. So our goal is to assess for the presence as well as the function of splenic tissue, and then to monitor these patients in terms of their overall immunologic function, with intervals as appropriate depending on the patient's condition. So the causes of asplenia are fairly numerous. It is estimated that there are approximately 1 million patients in the United States who are asplenic or hyposplenic. The more common causes of asplenia include trauma and surgical removal. There can be therapeutic reasons for splenic removal, including immune thrombocytopenic purpura, autoimmune hemolytic anemia, and hereditary spherocytosis. Fortunately, due to some of the advances in medical management of these patients, splenectomy is becoming a lot less common. Certainly, patients with sickle cell disease are well described to undergo a process of autoinfarction, leading to functional asplenia or hyposplenism. Less common causes of asplenia include isolated congenital asplenia and heterotaxy syndrome, which is important to us all here today. But there are numerous causes of asplenia and hyposplenism shown in this slide here. There are congenital forms, including asplenia, as we'll be discussing, heterotaxy, as we'll be discussing today, as well as a number of gastrointestinal disorders, hematologic and oncologic diseases, and immune deficiencies and immune deficiency syndromes can also lead to impaired splenic function, and a number of infectious diseases are well described to impair splenic function, and there can also be iatrogenic causes of impaired splenic function. Heterotaxy, as you are all well aware, can be characterized by left versus right isomerism. Left isomerism is also called polysplenia syndrome, and that is characterized by bilateral left atria, 2 bilobed lungs, and multiple spleens. Right isomerism, however, is characterized by asplenia, also referred to as Ivermark syndrome, is characterized by bilateral right atria, 2 trilobed lungs, asplenia, and tends to be associated with more cardiovascular malformations. So the spleen plays a really critical role in the immune function and normal host defense. It is a secondary lymphoid organ. Spleen functions include filtering blood to remove old, damaged blood cells and other damaged cells. It is also a critical site of immune responses to pathogens through both innate and adaptive immune systems. Roughly speaking, the spleen is divided into two main anatomical regions, including red pulp, which is a sponge-like structure where blood is continuously filtered in cords and sinuses, again, to remove damaged cells as well as to detect and remove pathogens. The white pulp is the site where adaptive immune responses occur, and that consists of CD4 positive and CD8 positive T cells in the periarteriolar lymphoid sheath. And it also contains follicles, which are a source of B cells. The marginal zone of the spleen contains dendritic cells, macrophages, and B cells known as marginal zone B cells. And these are a subset of B cells which function in a T cell independent manner, and they are able to mount prompt responses against a variety of viral and bacterial pathogens. So the infectious consequences of asplenia and hyposplenism are what we're most concerned about. Impaired splenic function can lead to overwhelming sepsis due to encapsulated organisms such as strep pneumonia, Haemophilus influenza type B, as well as Neisseria meningitidis. Encapsulated bacteria are protected from complement activation, and they resist engulfment by macrophages and neutrophils, and that is what makes them particularly virulent. Strep pneumonia has been shown to be the main cause of overwhelming post-splenectomy infections. Haemophilus influenza type B is the next most common infection. But other microorganisms can be problematic, including Pseudomonas, Capnocytophaga, Bartonella, and Babesia. Although the incidence of fulminant sepsis is fairly low at 3 to 7%, the mortality from sepsis is up to 70%. So very significant, very concerning. And the risk of sepsis is highest in young children under 3 years of age, as well as older adults over 60 years of age. So some of the techniques that we have available today to assess splenic function includes imaging such as MRI and CT, as well as abdominal ultrasound. This is the gold standard for diagnosis of asplenia, and it's important to note that spleen size doesn't necessarily correlate with splenic function. Functional studies include Howell-Jolly body counts in the peripheral blood smears. Unfortunately, this is a very insensitive way of assessing splenic function and is not preferred. The preferred method is an assessment of pitted red cell counts, and this can be sent to specialized labs. Our preference is to send to Cincinnati Children's Hospital. They have been quite reliable with quick turnaround times. The other assessment that we can perform is to quantitate IgM positive memory B cells. This particular population of B cells is predominant in splenic tissue, and decreases in IgM positive memory B cells can be seen commonly in patients with asplenia. So the pitted red cell count is an assessment of red pulp function. Review of the literature reports generally under 4% pit cell count in healthy individuals. Pitted red cell count greater than 4% is considered to be indicative of hyposplenism. As mentioned previously, we send our assessments for pitted red cell count to Cincinnati Children's Hospital. This requires 3 mLs of blood, refrigerated and shipped overnight. And their standard for normal range is considered less than 1.5%. So it's a bit more rigorous than what is currently reported in the literature. Lymphocyte analysis can be done at a number of immunology labs. We do our own assessments in-house here at Boston Children's Hospital. So we have a panel that assesses populations of naive B cells, as well as unswitched memory B cells and switched memory B cells. The production of IgM memory B cells from germinal centers outside the spleen may actually decrease the sensitivity of IgM memory B cells as a biomarker of splenic function. With time, patients will develop a relatively normal population of these cells due to production in lymph nodes. So a critical aspect of our management of these patients and keeping them safe from overwhelming infections is adherence to routine childhood immunizations, which is shown on the left here. And this will include immunization against strep pneumococcus as well as Haemophilus influenza B. Nowadays, we have availability of Prevnar 20, which provides immunologic protection against 20 out of 23 of the serotypes of pneumococcus, which is significantly better than previous Prevnar formulations, which included only 7 or 13 serotypes. So this is a big step forward, and I think a wonderful development for protecting our vulnerable patients. When patients are greater than 2 years of age, we can further enhance their protection from pneumococcal disease by administering Pneumovax. The necessity of Pneumovax, sort of in the era of Prevnar 20, is probably not as important, but it can provide some additional protection. Also important is to provide protection against meningococcal disease. So for our patients greater than 2 years of age, we recommend Menactra. For children under 2 years of age, we recommend Menveo, which can be given in 2 doses in children 7 to 23 months of age, typically given at least 12 weeks apart. Our patients are also susceptible to group B meningococcal infections, and Bexsero is recommended for our asplenic patients once children reach 10 years of age. So we do recommend monitoring titers perhaps every 5 years and revaccinating as needed. It is also critical for them to receive yearly influenza and COVID vaccine because severe viral infections can be a setup for overwhelming secondary bacterial infections. So it's important to try to minimize risk of these severe viral infections. Another important aspect to keep in mind regarding these vaccines is that Menactra cannot be given with different protein conjugate vaccines because it can interfere with development of the immune response. So this slide just reviews some of the different options for meningococcal vaccine. As mentioned, for the younger kids as young as 8 weeks of age, Menveo can be given in a 4-dose series, or it can be given as a 2-dose series for older infants 7 to 23 months of age. Menactra is given to patients typically greater than 2 years of age, and Bexsero provides protection from group B meningococcus given to our patients who are greater than 10 years of age. Another important aspect of our management for asplenic and hyposplenic patients is antibiotic prophylaxis, which has been shown to significantly increase the incidence of serious bacterial infections. Two options include amoxicillin given twice daily or NBK given twice daily. For our patients who are allergic to amoxicillin and penicillin, alternatives can include macrolides or cephalexin. We also counsel our patients that they do need to receive immediate medical care following animal bites due to a risk of capnocytophagia infection. We also discussed the possibility of providing emergency antibiotics for fevers, including Augmentin at a dose of 45 milligrams per kilogram twice daily. And we also recommend peri-procedure prophylaxis with amoxicillin 50 milligrams per kilogram an hour prior to procedure. So also an important aspect of our visit with these patients is to review a fever protocol for asplenia and hyposplenia. We discuss with these patients that impaired splenic function can lead to increased susceptibility to infection with these encapsulated bacteria, and these infections can progress very rapidly and can be fatal. So our recommendation, which is fairly standard, is to seek medical attention for fevers greater than 101 degrees Fahrenheit or 38.3 degrees centigrade. And of course, if they have other signs of systemic infection, such as chills, rigors, vomiting, diarrhea, or headache, again, they should immediately be taken to an emergency department for evaluation and blood cultures. Typically, we recommend administering Rocephin or Unicin to these patients pending negative blood cultures. For patients who have only mild illness symptoms consistent with viral respiratory tract infections without fever, they can be monitored at home. We also would recommend consideration of providing a prescription for Augmentin for patients who are remotely located and don't have rapid access to medical attention. They can start the medication at home and then proceed to the nearest medical facility that is available. So our standard immunologic assessment for patients with heterotaxy includes an in-depth review of their medical and surgical history and reviewing imaging studies that are available to assess for the presence of splenic tissue. And typically our lab work consists of a CBC and differential, as well as an assessment of quantitative immunoglobulins, which include IgM, G, A, and E, and also a measurement of specific antibodies to pneumococcus, Hib, and meningococcus, as well as tetanus in our patients who have received their vaccination series. We also perform lymphocyte immunophenotyping, which includes memory T and B cells and marginal zone B cells. And this can help give us an assessment of whether or not there is intact splenic function, and of course, our preferred pitted red blood cell count. Follow-up for these patients can vary somewhat depending on the complexity of the patients. Typically, early on, we will monitor these patients yearly and then space out the visits as appropriate. For patients who may have had an immunologic assessment concerning for possible underlying immune deficiency, we will clearly keep an eye on them a bit closer. So some other immunologic considerations for our heterotaxy patients include the possibility of impaired T cell populations. And for patients who have the more severe heart defects and have required surgical correction and thymectomy, they can be particularly susceptible to T cell lymphopenia, particularly in patients who have had thymectomy under a year of age. Studies of these patients have routinely demonstrated reduced numbers of T cells, both CD4 and CD8 positive T cells, a reduced population of naive T cells, and a reduced TCR repertoire. Again, this is more concerning and more significant in patients who have undergone thymectomy under a year of age. The clinical significance of the T cell lymphopenia isn't absolutely clear at this time, and it will require further follow-up. But potential late effects can include premature immunosenescence of T cell compartments, and this can be exacerbated by viral infections like CMV, which is a very potent T cell activator, and it can deplete naive T cell populations, particularly in a setting where there is already a reduced population of naive T cells. And severely reduced naive T cell populations can theoretically result in autoimmunity, higher susceptibility to neoplasms, and increased infections. So possible ways that we can minimize these risks are to include minimizing the amount of thymic tissue removed and consideration of autografts of thymic fragments, although this is not something that is routinely done, but thymic transplants are performed in patients with athymia due to complete DeGeorge syndrome, and that has been very successful for those patients. So I hope you found this discussion of the immunologic management of heterotaxy patients with asplenia or polysplenia helpful, and I will be happy to discuss any questions that you may have at the end of this section.